Hello everybody. Today we are going to discuss about EASL guidelines on hepatic encephalopathy. So, in upcoming discussion, we will mention whether this recommendation is strong, weak, or open. So, strong means we must follow that recommendation. Weak means we may or may not follow. So, first question is, in patient with hepatic encephalopathy, can predefined classification criteria may improve the diagnostic accuracy or not? So, as long as we are talking about hepatic encephalopathy, it is divided into type A, type B, and type C. So, type A is related to the acute liver failure. Type B is associated with portosystemic shunt without significant liver disease. And type C is associated with cirrhosis with or without portosystemic shunt. So the next classification is based on covert hepatic encephalopathy and overt hepatic encephalopathy. Covert means there are minor or no minor cognitive impairment which can only be detected by neuropsychological and neurophysiological tests. Overt hepatic encephalopathy means it will include the West Haven grade from grade 2 onwards. So now again this hepatic encephalopathy is divided into recurrent and permanent. So if there are more than two bouts of hepatic encephalopathy over a period of 6 months, then it is labeled as episodic or recurrent. And when we are calling it as persistent, if it is lasted for more than 6 months, and if there is no baseline written of normal neuropsychiatric performance between these two bouts, then it is termed as persistent. So again, I am repeating the definition of persistent hepatic encephalopathy. So as I mentioned before, recurrent means there should be the two episode of hepatic encephalopathy over a period of 6 months or more than at least two. And when it is called it as persistent, if there is no written of normal or baseline neuropsychiatric performance between these two episodes, then it is called as persistent. So now we have identified its hepatic encephalopathy. We have also known we have also correctly classified it. Now the next job is to know what are the precipitating events. So the precipitating events are constipation, gastrointestinal bleeding, infection, hyponatremia, dehydration, and diuretic overuse. So now the next question is whether to go for West Haven criteria or whether to go for Glasgow Coma scale. So what are the recommendations is this is having this statement is having strong recommendation. What they are saying is when the patient is in covert state, that means only in mild cognitive impairment state, then the only way to diagnose this neuropsychological or neurophysiological test. But when the patient is falling under the grades West Haven criteria of grade 3 to grade 4, then we have to also add the GCS. So let's have a look on what is this West Haven classification. So the West Haven classification is broadly divided into covert and overt. It includes the grade 0 and grade 1. So grade 0 is minimal psychomotor and neuropsychological alteration. Grade 1 is only trivial lack of consciousness, shortened attention span. Then overt includes grade 2, 3 and 4. Grade 2 is ataraxis, grade 3 is somnolence semi-stupor, and grade 4 is coma. So how does the term brain failure in patient with acute and chronic liver failure relate to hepatic encephalopathy? So brain failure should be replaced with the term with hepatic encephalopathy. So we should not label this hepatic encephalopathy as acute encephalopathy because these two are different terminologies. So again, this classification is not depend upon the underlying liver etiology of the underlying liver disease. Again, this statement has the strong recommendation. So, in patient with suspected hepatic encephalopathy, can exclusion and identification of alternative and additional cause can improve the prognosis. So, let's have a look what EASL guideline has are saying about this. So, what they are saying is alternative and additional cause of neuropsychiatric impairment should be identified to improve prognostic accuracy. Again, this treatment has very strong recommendation. So to rule out the alternative cause, first we should know what are these alternative causes. Because these extrahepatic causes are present in 22% of cases which are contributing to hepatic encephalopathy. So these causes are infection. The most common is urinary tract infection or pneumonia. Then perfusion disorders like stroke, MI, and other neurological causes like subdural hematoma. So how we should plan our diagnostic work? So diagnostic workup should include like a blood tests like glucose, electrolytes, inflammatory markers, full blood count, blood alcohol level, ammonia, TSH, brain imaging, screening for psychoactive drug, lumbar puncture, and EEG. Then concomitant disorder that must be considered are infection, hyponatremia, renal dysfunction, hypo and hyperglycemia, alcohol, drug abuse, intracranial bleeding, thiamine deficiency, malnutrition, or hypothyroidism. So now the next question is this mild cognitive impairment of an etiology other than liver function can show the similar features. So yes, there is a significant overlap between this covert hepatic encephalopathy and mild cognitive impairment of other etiology. So we should be very vigilant whether before labeling it as hepatic encephalopathy, we must rule out other causes of hepatic encephalopathy. So, in patient with the delirium, is ammonia measurement useful for the purpose of diagnosis, differential diagnosis, treatment, and prognosis? So, as I mentioned before, there is a significant overlap between the covert hepatic encephalopathy and mild cognitive impairment, which is caused by other etiology. So, how to differentiate that? Yes, the serum ammonia level will be very useful in this. So plasma ammonia level should be performed because the plasma level ammonia level is normal, then that brings the diagnosis of hepatic encephalopathy in question. We can absolutely exclude hepatic encephalopathy if our plasma ammonia levels are normal. Again, this statement has very strong recommendation. So, what is this? Ammonia plays a central role in the pathophysiology of hepatic encephalopathy. But so, and the blood ammonia level has direct correlation with the severity. Ammonia level may remain elevated even after resolution of hepatic encephalopathy. But this normal ammonia level is normal, then it has negative predictive value. Yes, we can safely exclude hepatic encephalopathy. Now, what is the treatment of it? So, ammonia lowering is inconsistently associated with clinical treatment response, and ammonia levels are not used to monitor therapy. Hospitalization rates were shown to increase in patients with ammonia 1.5 times the upper limit of normal. So, tailoring hepatic encephalopathy therapy with ammonia monitoring cannot be routinely recommended. Now about the prognosis. Hyperammonemia is associated with the decreased transplant-free survival from acute decompensation of cirrhosis. Although prognostic value of ammonia in patient with cirrhosis remains unclear. So, should patient with cirrhosis and delirium undergo cerebral imaging? So, patient with delirium and encephalopathy and liver disease, if we'll go for CT scan and MRI, then it should be performed only if we have any diagnostic doubts on if the patient is not responding to our treatment or because by doing CT or MRI has no diagnostic significance. The only only if our diagnosis is in question, or if we are thinking about other differentials, or if our patient is not responding to our treatment, then only we should go for CT scan or MRI. So there is no cerebral imaging proves the diagnosis of hepatic encephalopathy. So the next question is, in patient with cirrhosis, should covert hepatic encephalopathy should be screened for in clinic and wards, and how? So as I mentioned before, there is very thin line which is differentiating the covert hepatic encephalopathy and mild cognitive impairment of the other etiology. So how should we diagnose it? What should we do exactly? So their recommendation is, in patient with cirrhosis with no history of overt hepatic encephalopathy, screening for covert hepatic encephalopathy should be performed with the test for which experience and tools and local norms are available. The only bedside test available is animal naming test, which is worthy of further study and validation. Again, this statement has strong recommendation. So how to do this? The test can be neuropsychological or neurophysiological. Neurophysiological tests have an advantage of being closer to disability one is attempting to measure. The neuropsychological animal naming test has recently been shown to improve favorably with more established covert hepatic encephalopathy measured and to predict overt hepatic encephalopathy. So, does screening for covert hepatic encephalopathy enable the treatment initiation and overt hepatic encephalopathy prevention? So, if we have diagnosed this covert encephalopathy correctly and we have initiated treatment for hepatic encephalopathy, so the question is, can we prevent this overt? Can we prevent this patient? Can we prevent this hepatic encephalopathy progression? So the answer for this question is yes. If we have started treatment at correct time, that means if we have diagnosed this covert hepatic encephalopathy and we have initiated treatment with non-absorbable disaccharides, then yeah, it is definitely going to make the difference. Again, this statement has strong recommendation. So the next question is, in patient with liver failure and hepatic encephalopathy, liver support system has has any treatment can we treat that condition with the liver support system? So the liver support system like albumin dialysis can ameliorate hepatic encephalopathy and can be considered. But yes, the further studies are needed to prove its beneficial effect. So, in patient with overt hepatic encephalopathy, does the prevention of further decompensation and worsening of underlying liver disease improve the prognosis? Yes, all the measure to control the progression of underlying liver disease should be taken, and yes, we should identify the precipitating cause correctly and we should treat it. Both of these statement has very strong recommendation. So in patient with the overt hepatic encephalopathy, uh, which criteria should be used to guide admission to intensive care unit? So overt hepatic encephalopathy of grade 3 and 4, they are at risk of aspiration, and it's not a great idea to manage this patient in ward. So if the hepatic encephalopathy is progressing, then immediately we should shift the patient to the ICU for the further management. In patient with overt hepatic encephalopathy, which criteria should be used to guide referral to the hepatic transplantation? So, a patient with the recurrent and persistent hepatic encephalopathy. So, as I mentioned before, what is how to define recurrent and what is persistent? So recurrent means if the patient has more than 2 episodes of hepatic encephalopathy in past 6 months, then we should label it as recurrent. And persistent means if between these 2 episodes, if the patient is not returning to the baseline state of consciousness or baseline state of its cognition, then it is defined as persistent. And yes, we should consider this patient for liver transplantation. So, in patients who have had the first episode of overt hepatic encephalopathy, should secondary prophylaxis be initiated to prevent further episode? Yes, we can initiate this secondary prophylaxis to prevent further progression. And what we should start? The lactulose is recommended as a secondary prophylaxis following first episode of overt hepatic encephalopathy and should be titrated to obtain 2 to 3 bowel movements per day. And yes, we can also consider adding rifaximin as an adjunct to lactulose as a secondary prophylaxis following more than one additional episode of overt hepatic encephalopathy within 6 months of first dose. So both of these statement has a strong recommendation. The prophylaxis of hepatic encephalopathy should be used in an acute bleeding episode in patient with cirrhosis. So as I mentioned before, the GI bleeding is one of the precipitating factor for hepatic encephalopathy. So if our patient presents with GI bleeding, then rapid removal of the blood from GI tract by using lactulose or mannitol can be used to prevent hepatic encephalopathy. Again, this statement has strong recommendation. Now, the next question is, should prophylaxis of hepatic encephalopathy be used before TIPS placement? So, in patient with cirrhosis and previous episode of overt hepatic encephalopathy, rifaximin can be considered for prophylaxis of hepatic encephalopathy prior to non-urgent tips placement. Yes. So according to this, rifaximin has definitive role if we are planning for tips. Now the next question is, when should prophylactic therapy for hepatic encephalopathy should be discontinued? So the answer for this question is, in patient with history of overt hepatic encephalopathy with improvement of liver function and nutritional status and in whom precipitant factors are controlled, then discontinuation of anti-hepatic encephalopathy therapy should be considered. Now in patient with hepatic encephalopathy, zinc supplementation as a treatment option means we can consider zinc supplementation as a treatment option. So, according to this guideline, routine zinc supplementation is not recommended. Again, this statement has strong recommendation. That means we should follow this in our clinical practice. So, whether vitamins and micronutrient supplementation will help. So, vitamin and micronutrient deficiency should be treated as they can compound for they can aggravate the underlying hepatic encephalopathy. So, in patient with the recurrent and persistent hepatic encephalopathy, is identification or wherever or where possible the obliteration of photosystemic shunt a treatment option to improve outcome. So, obliteration of accessible portosystemic shunt in patient with cirrhosis with recurrent and persistent hepatic encephalopathy can be considered in stable patient with MELD score of less than 11. So, yeah, again the same question, if patient is presenting with the recurrent and persistent hepatic encephalopathy, then yeah, we should go for liver transplantation. Again, this statement has strong recommendation. Now, in patient with hepatic myelopathy, whether liver transplantation should be considered as a treatment option. So, in patient with hepatic myelopathy, yes, liver transplantation is definitely going to make a difference. Let's have a look on what is hepatic myelopathy. Hepatic myelopathy is the rare complication of cirrhosis that is most often accompanied by extensive portosystemic shunt. It is characterized by rapidly progressive spastic paraparesis without sensory deficit or sphincter dysfunction, and it does not respond to standard therapies for hepatic encephalopathy. So after months of progression, the patient either depend on walking aids or become wheelchair dependent. So for differential diagnosis, yes, we can go for spinal MRI to exclude other possible cause of myelopathy, which is vitamin B12, thiamine, and copper deficiency. So patient with the clinical signs of hepatic encephalopathy who underwent liver transplantation had similar outcome as patient transplanted due to other forms of hepatic encephalopathy. So in patient with cirrhosis related Parkinsonism, are dopaminergic drug a treatment option to improve outcome? So the answer for this question is cirrhosis related Parkinsonism, yes, the dopaminergic treatment should be tested. Again, this treatment has the strong recommendation. Is so what they're saying is if our patient is presenting with recurrent or persistent hepatic encephalopathy, fecal microbiota transplantation is going to improve outcome or not. So FMT is not routinely recommended as a treatment option, but its validation in large randomized placebo controlled trial is warranted. That means, as of now, this fecal microbiota transplantation has no role, but yes, definitely in future we need more studies to means to determine its efficacy. So in patient with cirrhosis and covert hepatic encephalopathy, if it is useful to institute treatment for the purpose of differential diagnosis and to reduce the likelihood of developing overt hepatic encephalopathy. So what they're saying is in patient with covert hepatic encephalopathy, anti-hepatic encephalopathy treatment should be considered for the purpose of differential diagnosis and to prevent overt hepatic encephalopathy. This statement has very strong recommendation. That's why it's very important to diagnose the patient who has covert hepatic encephalopathy. Because if we'll treatment the start the treatment early, then definitely we can prevent the progression of the disease. So now the next question is in patients with cirrhosis who are considered for TIPS, which neurological workup should take place to reduce the to access the risk of post TIPS hepatic encephalopathy? As we all know, the most common side effect of TIPS is hepatic encephalopathy. So in patients who are scheduled for non-urgent TIPS, the presence and history of overt and covert hepatic encephalopathy should be throughoutly assessed. One single episode of hepatic encephalopathy is not an absolute contraindication, especially if precipitated by the bleeding. Thank you guys.